Okay, so let me just start by defining what I think MECFS in very, very broad terms. Okay, so it is a new and nuanced debilitating fatigue, which has been present for over 6 months, and which has as a very characteristic feature a prolonged but a delayed worsening of all the symptoms by any physical, mental, and emotional overexertion. And these are not relieved significantly by rest and sleep. And the whole condition really is associated with brain fog, headaches, aching muscles and joints, sore throats, feeling faint on standing, hypersensitivity to light, sounds, and sometimes smell. We've already heard that the condition can be precipitated or associated with a number of infections, but sometimes it can actually occur after a lot of physical exertion or mental overactivity or mental trauma, and sometimes after biochemical and pharmacological agents. There are rare cases associated with vaccinations, and of course, in some situations, we don't know what the precipitating factor is. We know that the condition is to be increased in people who have joint hypermobility syndrome and with postural orthostatic tachycardia syndrome. The condition is more frequent in females and peaks in teenage years as well as in middle age. I think that the condition is probably under-recognized in the elderly, and as we've heard a little bit about therapies, it is actually quite resistant to many of the therapies that are being used at present. Now look, this is a really simple slide which sort of summarizes the main symptoms that we see in this condition, and I've produced a sort of an acronym at the side of champions, which I hope all of us will be in regard to this condition in the future. So C for concentration issues that people with ME had, H for headaches, A for arthralgia or joint pain, M for myalgia or muscle aches, M again for memory problems, P really for the very important post-exertion malaise, I represents intolerance to bright lights, sounds and smells, O for orthostasis, I feeling faint on standing, imbalance, that sort of thing, N for non-restorative sleep, and then S for sore throats with glandular enlargement in the neck and flu-like sensations. But the physical signs in this condition are few. So we really rely upon the clinical history to make the diagnosis. Now, what signs there are detailed here. So we particularly look for joint hypermobility syndrome and we try and undertake a Baton score. We know that a lot of people will have an increased resting heart rate. Their respiratory rate is also mildly increased, and this is something that's not often written about. And it has consequences because it increases the alkalinity of the plasma, which then contributes to alterations in ionic calcium and magnesium, and then subsequently in muscle function and mitochondrial energy generation. Virtually everybody with MECFS find that their hands and feet are cold, and even when the external temperatures of a moderate degree is in this condition, which are altered. And I can talk about that later if required. Now, we've heard about some of the research criteria. I'm not going to say much about them, apart from the fact that they all, or that certainly these three here, the Canadian, the ME, and the IM, need post-exertional malaise as a compulsory feature. In the earlier ones, it was not so evident. But there are a number of other symptoms which are required to make the diagnosis and which are present in a large number of patients, large proportion of patients. There are, of course, a number of exclusion criteria, and these have been detailed in the past, but very briefly, if you have chronic fatigue, then we need to make sure that that is not due to any underlying medical condition that may be associated with fatigue. We know that any form of significant depression or melancholia or psychosis is also associated with fatigue, so we try to exclude this. The same also with dementia, and people with anorexia nervosa or bulimia nervosa also complain by a lot of fatigue, and this would be managed differently to the MECFS. And then, of course, it stands to reason that fatigue may be present in people who have organ failure or chronic infections We know that in SLE, Sjogren's syndrome, rheumatoid arthritis, and these rheumatic conditions, which are associated with chronic inflammation, the frequency of chronic fatigue can be as high as 90%. Also, people with a variety of major neurological conditions will have chronic fatigue, and those that require systemic treatment, endocrine issues, and of course, primary sleep disorder. But we've used the term ME/CFS as one, but there are a lot of patients who want to draw a distinction between the two conditions. And in brief, I've just mentioned some of the features that ME patients say they have, in contrast to those who may simply have chronic fatigue syndromes. So ME patients have been considered to have more significant prolonged post-exertion malaise, they have more neurocognitive dysfunction, and they are systemically unwell. The fatigue and the other symptoms are in general more severe in ME, more frequent and prolonged. And then there's mention of the DePaul symptom questionnaire in trying to differentiate between the two conditions. Now, although there are a lot of criteria for diagnosing ME/CFS, they are really made for research purposes. And it's very hard to use these in the clinic room. And so what I did a few years ago was to look at all the symptoms and try and arrive at a scoring system that may be useful. And this is what I've come up with. So we've used this in probably 8,000–9,000 patients, and it seems to hold up very well. So you heard me mention about the delayed prolonged post-exertion malaise after the physical mental emotional. This is the most important symptom in ME/CFS. And as you heard me mention earlier, the more recent criteria make this a mandatory criteria. So in the case of the scoring system that we developed, this attracts a score of 3, whereas non-restorative sleep, which is also very frequent in ME/CFS, has a score of 2, while the other symptoms like the impaired concentration, the reduced short-term memory, headaches, sore throats, joint pains, muscle aches, postural instability, and hypersensitive sightings and smells, they all attract a score of 1. That gives a total score of 13. And in order really to be fairly confident in making the diagnosis of ME/CFS, you need to have at least 8 or more out of 13 points to be able to be more confident about this diagnosis. In terms of the post-exertion malaise, it really needs to be delayed and it needs to be prolonged to get the full 3 points. And if you have lesser degrees of these, then you have 2 points or 1 point. And then the fatigue and the neurocognitive problems, myalgia, etc., they must be present for at least half the time. And then sleep disturbance I've indicated here. Remember that difficulty initiating sleep really must be longer than about 30 minutes and must occur 5 days, 5 nights of each week. And again, sore throats, these must be regular or frequent and not just the odd sort of sore throat here and now and again. But you have to be you have to exercise great care when you have somebody who has significant anxiety or depression, because firstly, both depression and anxiety can be associated with fatigue, but depression and anxiety can complicate CFS because this condition is very hard to explain. It exacerbates unpredictably, and there are very, very few treatments available. So you have to be careful in the situation where you have significant associated depression and anxiety. For our research, we use 10 or more points, and other features that can help make or confirm the diagnosis of ME/CFS are these interesting things that we see in patients, such as the vast majority are hypersensitive to medications, particularly SSRIs, SNRIs, and tricyclic agents. They also have a very high frequency of alcohol intolerance, and it is very rare to see a patient with ME/CFS who can tolerate 4 or more units of alcohol in a single sitting. In fact, I find that very, very rare. And then from a clinical perspective, you can have additional points that might suggest the diagnosis of ME/CFS in borderline cases if they have the cold peripheries, alcohol intolerance, drug hypersensitivity, and also the altered pupillary reflexes and sighing respiration. And if you have 3 of these, then you attract an additional point. So what are the conditions that can mimic chronic fatigue syndrome ME? Well, you heard me mention earlier about joint hypermobility syndrome and POTS. We know that they can predispose to it, but we don't know how this works. The other conditions worth considering are the endocrinopathies, particularly hypothyroidism, Addison's disease, and pituitary dysfunction, and the systemic connective tissue problems. Interestingly, celiac disease and gluten sensitivity is also associated with a high frequency of fatigue, and quite often that can be the predominant symptom rather than the gut manifestations about which we are all aware. And then persistent anxiety and depression can mimic chronic fatigue, as can primary sleep disorders. In my experience, I've seen a few patients where they've been referred with chronic fatigue, but what they actually have is cardiac dysfunction or early Parkinson's disease. Temporomandibular disorders have also been mentioned. I won't touch on those again, but they are important. So what about people who have depression? We know that they have a high frequency of feeling fatigue. How can you differentiate fatigue that is present in depression from that which we see in chronic fatigue syndrome, ME? Well, in terms of the physical exertion, we know that in patients, exercise can improve mood and energy levels, but in ME/CFS, nearly always the exertion causes a delayed worsening. In depression, the mood is nearly always low, but interestingly, if you ask patients with ME/CFS about their mood, they'll be at pains to stress that they don't feel sad, they don't feel depressed. In depression, motivation is reduced, whereas it's normal in ME/CFS. Sleep, in people in depression, they have early morning awakening, but difficulty initiating sleep can also be seen, whereas in ME/CFS, it's quite often difficulty initiating sleep and finding enough energy to get up in the morning. Memory, I've indicated the features here, word finding difficulty in CFS ME. With concentration in depression, it can be normal, but it's nearly always impaired in ME/CFS. And then the other features I've indicated here, such as the level of energy, appetite, affect, and interest in outside life, and response to antidepressant, which of course may improve the fatigue and depression, but really appears to have very little effect in people who have ME/CFS. And these are the findings that I've highlighted here, the important points. So how do we measure physical and mental fatigue? This is a difficult issue. Well, the things that we use in the clinic and ask patients to do at home, they can time how long it takes to walk a set distance, or they can use a pedometer or a smartphone to measure the number of steps they take. Mentally, they can time how long it takes for them to read 2 to 5 pages. On a more sort of research footing, sometimes one of these dot-to-dot books where you have to join the dots to make a picture, you can time how long that takes. You can try simple arithmetic questions, but we really need new apps to be created to assess mental function, which is very difficult. And we rely on the patient to tell us if they are feeling that they are mentally sluggish as a result of their condition. So what about the investigations? Having taken your full history, looking particularly for the delayed post-exertion malaise and non-restorative sleep, aching muscles, joints, sore throats, etc. What sort of investigation should we do? Well, in my experience, the most important routinely available investigations are listed here. In particular, a full blood count and ESR. The full blood count will obviously check for anemia. It will also look to see if there are any decreases or rises in the white cell counts and their fractions indicative of a lymphoproliferative problem. The ESR is actually an underrated test because it indicates chronic immune activation. And obviously it's raised in people who have systemic connective tissue disorders or chronic infections. The CRP is nearly always low in ME/CFS, but if elevated, suggests inflammation or infection. We always check the renal, liver, and thyroid function tests. I mean, there are dysfunction in each of these areas is commonly associated with fatigue. Now, low iron levels we look for because an iron deficiency anemia or low iron without anemia leads to reduced ATP production by mitochondria. But there is also literature on fatigue in patients who have hemochromatosis. And there you would look for additional signs of this condition in terms of altered glucose tolerance, joint pains, etc. We always check an autoimmune profile on a composite tissue block, which will look for the presence of anti-parietal cell antibodies, anti-smooth muscle antibodies, all those sort of things. And that can be helpful and reassuring if it's negative for the patient. You heard me mention earlier about celiac disease. We will look for anti-TTG antibodies to make sure an individual does not have that. And then, being an immunologist, we always look at immunoglobulins because a lot of our patients with primary antibody deficiency, and indeed with any form of combined immune deficiency, find that they are highly fatigued. We measure the vitamin D levels, and which are frequently low, but interestingly, it really doesn't help in the further investigation, and supplementation with vitamin D rarely helps the fatigue. And then there are a list of further more detailed investigations that we would do based on the clinical history, such as looking for anti-nuclear antibodies, those to extractable nuclear antigens, DNA, rheumatoid factor, CCP antibodies. If there's a lot of muscle tenderness, we look at the muscle enzymes, consider an EMG. And in older women and perhaps men, we may want to think about doing a DEXA scan. There's a lot of aching going on. And then if you suspect Addison's or Cushing's, you do a synaptin or dexamethasone suppression test. And then considering the role of infections, you may want to check the serology for these. And then if there are neurological problems, an MRI, functional MRI, et cetera, and then sleep studies. And if there are cardiac issues, 24-hour ECG and echocardiogram. And then there are certain very highly specific investigations which we would undertake only if there are specific indications, such as tilt table testing, 24-hour ECG monitoring, and MRI of the cervical spine in extension and flexion for atlantoaxial instability in people who have joint hypermobility syndrome. And then very rarely we might go on to do neuropsychological testing. But remember, there are a huge number of tests being offered out there on the internet. And in my opinion, it is presently difficult to advocate their use because first we don't have adequate treatment and we don't know in depth what they mean in the context of the fatigue. So there are autonomic receptor antibody tests available. That may become more important in the future when we have newer treatments such as BC007. And then a number of patients will come to you, they've had these tests of their T cell subset, their NK cells, B cells, but really they may be a reflection of the condition or the condition that precipitated them, but it really doesn't help in the, doesn't really help in the diagnosis or what treatments may be suggested. And then testing for triggering infections may be helpful in some situations, but often isn't. I mean, I deal practically with these individuals, so I tend not to do a lot of these tests. Clearly, with the COVID-19 pandemic, it may be appropriate to do the serological testing if the individual did not have a PCR-based swab or lateral flow test which confirm their condition. And then I've mentioned a whole range of other conditions here, but one thing I would like to highlight is that a number of companies offer serological tests for underlying infections. Remember that in CFS EMEA, there may be polyclonal B-cell activation, which means that they'll have non-specific IgM and IgG antibodies, which cross-react with a whole range of antigens. And so you can get false positive results to a number of viruses and other pathogens. So you should bear that in mind. So what are the factors that perpetuate chronic fatigue syndrome, Amy? Well, although this slide looks quite simple, it does indicate the interaction between all the important organ systems, systems in the body and how they contribute to the overall phenotype of the chronic fatigue syndrome. So when you have an initiating factor in the middle, it could be viral infection, it could be stress or a general anesthetic, whatever, that can then lead to chronic fatigue. And sometimes the whole condition starts with disturbed sleep, or it may start with a lot of stress or endocrine dysfunction or muscle factors. And sometimes, and not infrequently, there can be a gastrointestinal onset to the ME/CFS. But no matter how it starts, what happens is that, let's say, the initiating factor is a gastrointestinal dysfunction. We know that that can then lead to, because of permeability of the gut, can lead to muscle dysfunction. It can also lead to viral reactivation, and that can lead to gastrointestinal dysfunction. And of course, GI function can contribute to stress, particularly if there's a lot of IBS type symptoms with urgency of defecation. And so this diagram sort of indicates how all these factors interact with each other, but it also serves to highlight that if we want to manage this condition, we need to address each of these areas in order to improve the patient's illness and their prognosis. And then finally, this is the last slide, there are a huge number of treatments being suggested, and you'll no doubt be aware that pacing is very important, as is deep relaxation, meditation, and I often recommend breathing control. We don't now use GET, and in fact I never have, because in some instances it can make the condition worse. And I only use CBT in rare cases if I think there are issues with the patient's interpretation of their symptoms. Vitamin B12, vitamin D3, you've heard me mention, and then there are supplements that supposedly increase ATP production by the mitochondria, and some of these can be helpful in some individuals. And then I've listed here all the other sort of prescribed therapies that can be used, and you will see that there are SSRI and SNRI agents that are used, particularly there's an associated and complicated mood disorder, and then GABA agonists for pain, etc. Immunoglobulin has been used in a very small number of patients. The therapy is exceptionally expensive and very hard to initiate in the UK. And there are some reports that it can be helpful. And then melatonin for sleep, low-dose thyroxine, etc. can also be helpful. Some of the newer therapies that are being suggested is low-dose naltrexone and low-dose aripiprazole, which you will remember is Abilify. And then there are antiviral agents. And on the continent of Europe, people have also used low-dose doxycycline. There was, as you may recall, the use of rituximab as anti-B-cell therapy, which initially showed promise in ME/CFS, but subsequent work appears not to have supported that. So I'm going to finish the talk there, and that's it, and hand you back to, who am I handing back to? Diana?
To Diana, yes, thank you.
Okay.
Thank you so much for
Not at all.
your speech. Okay.